Hello, I'm Dr. David Unwin. I'm a GP in the UK, just north of Liverpool. And for the last 9 years, we've been offering a low-carb approach to the patients in my practice with really good results for remission and reducing medication for people with type 2 diabetes. This talk is about some of the things we've learned during those 9 years, but I'm focusing not really on type 2 diabetes, but on some of the other conditions linked with type 2 diabetes that I hope may be of some interest to you all. My conflicts of interest. So I should tell you that I'm biased towards the low-carb approach because I've been in nutritional ketosis now for 9 years. And for me, it's had amazing benefits in terms of my health. So I think I may be biased. But certainly I have no financial conflicts of interest. Nobody pays me to say anything. And occasionally, if they do, I donate that money to the Public Health Collaboration, a UK charity. So the talk today, we start with a quote. Before the diagnosis of type 2 diabetes, there is a long, silent scream from the liver. This is a quote from my friend, Professor Roy Taylor of Newcastle University. And he points out that there is a long, silent scream from the liver of about 10 years before the onset of actual type 2 diabetes. And it's factors to do with the liver that I'm going to explore in the next half hour with you all. So let's kick off with a patient. This is Chris. He's about 40 years old. He has type 2 diabetes, and it's unfortunately poorly controlled despite the medication I'm giving him. But interestingly, he has some other things too. He has a raised triglyceride level. He also has really abnormal liver function. And these are some things we're going to look at together because I think they're very important. They are actually linked to each other and also to mortality. And I feel that we don't talk enough about abnormal liver function and also raised triglyceride levels. And I wonder why that is, because they are important. And as I say, each of them is linked to all-cause mortality. In the early days, I was looking at the results at my practice, the Norwood GP practice, and I was astonished really to discover that when we looked at people who'd had blood tests on their liver, particularly the gamma GT, a very sensitive marker for liver health, of 4,753 patients who'd had a blood test, 24% of them had abnormal gamma GT results. Well, as I say, astonishing. Such a large number of people have abnormal liver function. And I really wondered why, what was going on. And also I didn't know what to say to my patients. How would I to guide them? And also, did it matter? In fact, it does matter. Some of you will have heard of the Framingham study, a famous study looking at cardiovascular risk. And in fact, they looked at liver function. And after an average of 19 years, one standard deviation increase in gamma GT brought about a 13% increase in cardiovascular risk. And even more worryingly, a 26% increase in the risk of death. In fact, the highest quartile of the people where they'd looked at the gamma GT, the top 25% experienced a 67% increase in cardiovascular disease incidence. So that a simple blood test, the gamma GT, would seem to be very interesting, and yet so many of my patients have a raised gamma GT, and what should I do about it? And presumably doctors all over the world have similar rates of abnormal gamma GT blood tests and are confused knowing how to best help their patients. A little bit more now on gamma GT, the liver function test I'm so interested in. This is a very interesting study that organized gamma GT results into 4 quartiles. So on the graph here, the red line is the cumulative incidence of cardiovascular disease for the top quartile, organized by gamma GT, and the black line underneath it is comparing patients who had the lowest gamma GT results. And you can see here, year by year, the ones with the raised liver function test had a very significantly increased cumulative incidence of cardiovascular disease, highlighting the importance of liver function tests. Look at the graph on the right. We're looking here at the cumulative incidence of mortality, because in a way we should all care rather more. It's not just about do we fall ill, but all-cause mortality is clearly absolutely vital. So again, we're looking at the red line, which is the top quartile of gamma GT, and the black line to compare the lowest quartile of gamma GT. And again, year on year, you're seeing a significant increase in the age sex adjusted cumulative incidence of all-cause mortality. So we shouldn't really be ignoring abnormal gamma GT. And yet, you know, for many years, that's exactly what I did, partly because I didn't know what to say to my patients, or other than just frightening them. I think many doctors are unsure how to help their patients once we've noticed abnormal gamma GT blood tests. Now then, the other thing we noticed in my practice was when we audited everybody's fasting lipid results, something stuck out, and it was the patients with a raised triglyceride level. So triglyceride is part of a lipid profile. So the fasting lipid profile will include cholesterol and HDL and the cholesterol ratio, but it also includes a fat called triglyceride. And here we are, out of 2,458 patients in my practice, an astonishing 32% had a high triglyceride level. And again, for years and years, I was so unsure how to help people with a raised triglyceride. I didn't really know what to say to them, and we fell into the pattern of just repeating the blood tests year after year rather pointlessly, and yet we weren't able to advise our patients. I think in part that's because statins, the drugs we use for cholesterol, don't really help with triglyceride. But we have a problem here because in my practice and many other practices, nearly a third of the entire population have a raised triglyceride. Worrying, but also fascinating. And again, when I look into the studies, an elevated triglyceride level is one of the single most powerful predictors of extensive coronary heart disease, particularly if you factor in also the HDL cholesterol and look at the ratio of the triglyceride against the HDL cholesterol. But for the moment, we're going to just concentrate on the triglyceride, and I just wanted to emphasize that we shouldn't be ignoring these blood results showing a raised triglyceride level. I think we should be interested in them, and be actively seeking how to help. At the moment, everything has to have a sort of COVID relevance. So this is an interesting study. It was looking at 1,400 patients in hospital with COVID, and it was looking at the lipid profiles for these patients and dividing them up into those who had a benign course of COVID and those who had a far more severe course of the illness. And what is interesting is that, yet again, triglyceride turns out to be very important, because if we look here at the differences in blue, which are the ones who have a mild course of the illness in hospital, and the orange, which is those that have a severe course, the difference in triglyceride between the two was very great. There was really no difference in total cholesterol or LDL cholesterol. The other relevancy was the HDL cholesterol, and that was also linked to a poor outcome with COVID. And in fact, I should point out there is a link between triglyceride and HDL. They tend to do the opposite. They are linked, but they tend to do the opposite. So as triglyceride goes up, HDL goes down, or conversely, as HDL goes up, triglyceride goes down. So it's interesting that these two things, triglyceride and HDL, were linked with much poorer outcomes for COVID. Back to the long silent scream from the liver. Now here's the thing. About 25% of the developed world has non-alcoholic fatty liver disease. Again, amazing. So a quarter of everybody you know has fatty liver disease that is not related to alcohol. So this is another question. What is going on where so many people have this problem? And just a little more on non-alcoholic fatty liver disease. This is one of my patients, and we're looking at the weight between 2004 and 2019, and you can see the weight climbing inexorably. And at the point here, we did an ultrasound scan. And interestingly, despite the fact that the liver function tests were absolutely normal, the ultrasound showed clear evidence of fatty liver disease. So the problem with fatty liver disease is even worse than my blood tests at Norwood Avenue would indicate, because it's possible to have normal liver function tests, and yet the liver has already filled with fat. I wasn't surprised recently to learn there's a new board game called Pandemic. So we're thinking all the time at the moment about pandemics. And no wonder, this is the latest update from the BBC News, and it's telling us that so far, horrifically, 3.3 million people have died around the world in the last more or less year and a half, I think it is now, of COVID. So this is a very serious pandemic. 3.3 million people have died. But let's just compare the situation with diabetes. So we have 463 million people are living around the world with diabetes. And diabetes causes 4.2 million deaths each year. So actually, arguably, this is worse than COVID, and it's happening every single year, and there's no vaccine for diabetes. And I just feel that we think a lot about COVID and how to help it. And should we not use the same amount of energy looking into preventing diabetes if it's actually causing 4.2 million deaths per year? And as I've said, non-alcoholic fatty liver disease is 25% of the developed world. So surely this is also a pandemic. the situation with obesity isn't much better. So there we are, 1.9 billion adults around the world are overweight. And look at the problem with children. In 2019, 38 million children under the age of 5 are overweight. So I just put this in really to say that, yes, a pandemic is a terrible thing, and COVID has made that point. But there are some other pandemics that we should be giving equal energy to trying to prevent. Let's get back to Chris here. So Chris, the patient here, he's got diabetes, but he's also got abnormal liver function and a raised triglyceride level. So common. So he's got all of these things. So how are they linked? And what can we do about it? The first thing is to just reassure you that we have sorted Chris out. So this was Chris years ago on the left, with type 2 diabetes, poorly controlled, fatty liver disease, raised triglyceride, high blood pressure, on medications which did not seem to be helping. And there's the good news on the right. Chris, 20 years later, off all medication, fatty liver cured, triglyceride normal, blood pressure normal, diabetes into remission. So Chris, in a way, is a very common patient. But here's a ray of hope that if we can sort out one patient, or what can work for one patient may work for others. So it's worth looking into really the question of, why did cutting carbs sort out all Chris's problems? What is the link between triglyceride, liver function, and indeed diabetes? Well, I often talk about insulin. So the hormone insulin is produced by the pancreas gland. It's got a very special job to do. Insulin is there to keep your blood sugar down, to keep you safe, because a high blood sugar over time damages the lining of your arteries. And that's what's wrong with diabetes, or people suffering from diabetes. Their blood sugar rises, and a raised blood sugar damages the lining of your arteries. So we need to take insulin very seriously. Here's a question. I mean, what does insulin do with that sugar? Well, it's pushing it out of the bloodstream and into cells where it's supposed to be. And of course, you need sugar inside your cells for energy. So the muscle cells require glucose for energy. But if you continue to consume more sugar than you need for your muscles, the extra sugar gets turned into a fat. In the liver, that fat is triglyceride. So here we have a link between a high carb diet, insulin, and triglyceride. Insulin also pushes sugar into your belly fat. And this is how we have a link between a high carb diet and central obesity. So there we are, a link between sugar, insulin, triglyceride, a fatty liver, and central obesity. And the work of Roy Taylor in Newcastle has shown that gradually, if you carry on taking in more sugar than you can deal with, your liver is turning to fat as the triglyceride begins to build up. And that fat in the liver affects the work of insulin. So you become less sensitive to insulin and develop what we call insulin resistance. This is half of the diabetes riddle. But as you continue to take in more sugar, than you should, your pancreas gland, the very thing producing that insulin, also begins to fill with fat, and you struggle to produce the insulin you need. And so this is perhaps the final part in the jigsaw, where having too much sugar in your diet through insulin is causing fatty liver, raised triglyceride, central obesity, and type 2 diabetes itself. The good news is, as we found at Norwood Avenue, if you reduce carbohydrate intake, that reduces circulating insulin, reducing the liver fat, reducing the insulin resistance, reducing the pancreatic fat, increasing insulin secretion, and actually putting type 2 diabetes into remission. And I should say that there are different ways to reduce carbohydrate intake that all work. So bariatric surgery works very rapidly, and people often come off insulin for type 2 diabetes in the first week after surgery. There's a lot of work now on very low calorie diets, which of course also reduce carbohydrate intake. So all of these things can reverse diabetes, but the great news is they also help with triglyceride levels and fatty liver disease. I also wanted to talk about sleep apnea, which sounds an odd jump from insulin, but these scans fascinated me. We're looking here at the amount of fat in the tongue between people who have sleep apnea and normal people. The yellow there is fat in the tongue, and it seems that for people with sleep apnea, it is this fat in the tongue, a fatty tongue, that is part of why people are struggling to breathe in the night. Sleep apnea, a very serious condition that's getting more and more common. And it's my hypothesis that insulin, as well as causing a fatty liver, is also contributing to the fatty tongue. I just want to show you another patient that I'm very proud of. This is Ruth, and she's another one of my low-carb successes. So this is Ruth before on the left and Ruth after over here, and a graph of her body weight. So I'm so proud of what Ruth has achieved. But Ruth had a number of other problems, and one of them was sleep apnea. And it's very interesting that during COVID, I've not been able to get any of my patients with sleep apnea seen in the appropriate clinic. But the good news is I've been trying each of them on low carb, and not a single patient with sleep apnea has actually needed to go to the clinic, because each of them has been sorted out by going low carb. And it's only a theory of mine, but I suspect that the reduced carbohydrate, the reduced insulin, is helping the fatty tongue you saw in the last slide. So here we are. The hormone insulin is pushing glucose out of the blood stream and into cells. In some cells, it becomes triglyceride. So here we have one of my brilliant patients, and we're looking here at the average blood glucose as the hemoglobin A1C for about the last 11 years. And you can see here a sustained remission of type 2 diabetes. If we compare the same time frame, you can see exactly the same has happened to the triglyceride, just helping make that link between triglyceride and blood sugar. So these graphs are synchronous. In both of them, you can see an improvement in the triglyceride and also the average sugariness of that patient's blood. So I'm just putting this forward to make the point. A high blood glucose is linked to a high triglyceride level. And if you have patients with a high triglyceride level, you should think about blood sugars. The other thing that I just like to hammer home is that drug-free type 2 diabetes remission can be sustained, because as you can see down here, You know, it's gone on now for about 9 years there. I'm so often told that, yes, what you do, Dr. Unwin, is very good, but it may not last. I'm finding that it does last. So at the moment, as I say, I think I've got 97 patients with type 2 diabetes remission. And the average time those people have been on a low-carb diet is nearly 3 years. It's, I think, about 31 months now. This is another patient from this year. And this patient presented with the highest serum triglyceride I'd ever seen in clinical practice, sky high, over 20. That was in January 2021. But look, by April 2021, that worrying triglyceride had plummeted. And at the same time frame, the diabetes has been pushed into drug-free diabetes remission. And again, I'm hammering home the point: a high blood glucose is linked to a high triglyceride level. And drug-free type 2 diabetes remission can be surprisingly rapid, which is very hopeful. So the hemoglobin A1C is a measure of how sugary your diet has been. And when I'm helping my patients who have a high hemoglobin A1C, I find it really helpful to ask them, where do you think the sugar has come from in your diet? So we're revising now how I get the good results at Norwood Avenue, and some tips really for any of you working with patients with a high hemoglobin A1C, or indeed fatty liver or a high triglyceride. I think the first priority is to cut out table sugar. This is in part because, of course, it supplies glucose, but it's a disaccharide, and the other half is fructose, and this is a potent cause of fatty liver disease, even though it doesn't put up blood glucose immediately. A reminder: sugar doesn't just come from sweet, sugary foods. Starchy foods like potatoes, like rice, like breakfast cereals break down into surprising amounts of glucose. So I think of starch as concentrated sugar. And for years, I didn't really discuss this with my patients, and I was wrong, because anybody now who's monitoring blood glucose carefully knows that starchy foods put up their blood sugar, and these need cutting out, or at least reducing, as well as the sugar. And many of you will have seen my teaspoon of sugar equivalents. These help people understand the glycemic consequences of their dietary choices. So that a small bowl of boiled rice can be expected to affect your blood glucose to a similar extent as 10 teaspoons of sugar. A bowl of boiled potato is approximately equivalent to 9 teaspoons of sugar. And so it is pretty obvious that you should eat something else if you have type 2 diabetes, fatty liver, or a raised triglyceride. And so I produce these infographics to help people understand what foods they should avoid. They're based on the glycemic load of these foods. There are actually 7 of these infographics, and they are published. If you Google PHC and Unwin and sugar, you will see all of these infographics, and they've now been translated, I think it's into 12 or maybe 13 different languages. On the right, you see Matt Hancock, who is our Minister of Health, and he agreed to have his photo taken there in Parliament because he's helping me promote the use of these infographics. There's how you would find the infographics on Google. And then before we leave this slide, we should just hear from Boris Johnson, our Prime Minister. And he went on to Twitter recently, and he said, "What I've been doing is I've been eating less carbs." Quite right, Boris, and I think many of us should follow your lead. This is the diet sheet that we've been giving out to our patients for 9 years now at Norwood Avenue. Basically, we're encouraging people to turn the white stuff green. Instead of rice, potatoes, bread, have far more green vegetables, and you should probably increase your protein intake as well. We did actually publish last year a cohort study, and in this we're looking at particularly liver function test, HDL, cholesterol, and also triglycerides for the cohort of patients at Norwood Avenue who have gone low carb. So at this point in the cohort, these people had been on a low carb diet for an average of 29 months. And if we look at the result, the gamma GT liver test, it started off at 45, ended up at 29 on average. So we're getting a percentage improvement of 36%, which is really amazing and very encouraging. So it's highly, highly relevant. If we look at the HDL cholesterol, this is the protective cholesterol. So this went up. Again, good news. And it's improved on average by 8% and was highly relevant. The fasting triglyceride, that also improved by 27%. So particularly if you're looking at the triglyceride HDL ratio, which is such an important marker of cardiovascular disease, going low carb seems to bring about really substantial improvements for my population in Southport. This is just the box and whisker graph that we published as part of that there. And if we look, we're looking here at gamma GT, and so the red dot is the mean result at the beginning, and then over here on latest follow-up you can see how much it's dropped. The box and whisker is showing the basically the 25th is the bottom there of the box, and the 75th centile with the median in the middle. So if you look from the start of the intervention to the end, the entire population have moved over there. So these are very significant improvements in liver function. And in fact, when you actually break it down to see of the population on the left, how many of them are going to normalize their liver function, it was about 74%. Again, so encouraging. Let's just go back to, you remember the patient earlier that was very overweight and had an ultrasound scan confirming fatty liver despite the normal liver function blood tests. What was so good is between September the 15th and December the 9th in the same year, there was significant improvement on ultrasound of that fatty liver when the patient went low carb. And look at the improvements in weight there. These graphs, we call them just falling off a cliff, and they just drop like that. Eventually they usually stabilize. That patient hasn't stabilized yet, still dropping there. Just going back through another patient. So I looked after this lady for many, many years, and this is her gamma GT result going back to about 2003. I worried about her abnormal liver function, and it was actually for most of the time 3 times the upper limit of normal. I referred her to a hepatologist and 2 gastroenterologists. None of these people mentioned the possibility of carbohydrate intake. They all thought that she was probably drinking too much, and the poor lady was very upset because she really didn't drink, and yet she was being told off because the specialists all assumed that her abnormal liver function tests were due to alcohol. And yet you can see when she gave up sugar and starchy carbs, somewhere back in 2013, the liver function improved dramatically. such a relief for her and a relief for me. But maybe those specialists had something to learn, because all they did was worry her, and she felt humiliated by seeing those specialists. Going back to triglyceride and HDL, the same lady, also look here. So she had a high triglyceride, which I didn't understand. But now with the model I've shown you, the model using insulin, you can understand why her triglyceride has dropped since she's given up sugar and starchy carbs and remained so much better. I explained before that the protective HDL cholesterol tends to do the opposite of triglyceride, and you see that the HDL has gone up. So her overall cardiovascular risk has improved really very significantly by cutting up the sugar and starchy carbs. And these improvements in lipid profile have happened despite the fact that she had to increase her butter and cream in her diet because she actually lost too much weight. In clinical practice, losing too much weight is a very rare thing, or it was for me until 2013. Right, what about some broader evidence, an RCT? So here's an RCT looking at young people with confirmed non-alcohol fatty liver disease, and they were randomized to 8 weeks of a carbohydrate-restricted diet or a fat-restricted diet, which was the more conventional advice I was giving till 2013. And the results is after 8 weeks, the carbohydrate-restricted diet experienced significant decreases in hepatic fat content. The fat-restricted diet group showed no change. So I think this RCT is good evidence for cutting carbohydrates for people with non-alcoholic fatty liver disease. If you're looking to learn more, as part of the Royal College of General Practitioners, I have recorded a screencast. This is open access to anybody that's interested. If you go on the Royal College of General Practitioners website, there is a screencast here which touches on non-alcoholic fatty liver disease in more detail. So we've come to the end of my talk now. I really hope you found it interesting. And I hope now you can better understand why Roy Taylor talks about the long silent scream from the liver before the diagnosis of type 2 diabetes. I think there are some things we should be doing differently. We should be listening out for that long silent scream. We should notice it because we could take action earlier, so that if you have patients who have non-alcoholic fatty liver disease, this is important. We should be doing something. It is a pandemic. It needs action. The other thing is, if you have patients with a raised triglyceride or abnormal liver function, think about non-alcoholic fatty liver disease, particularly if they have central obesity. You should probably do a hemoglobin A1C or measuring a measure of fasting insulin if you can, and consider a low carbohydrate approach to help these patients. Don't wait until they have type 2 diabetes. So that's it from me. Such an interesting journey. I'm still learning, and the benefits of a low carbohydrate diet go way beyond just type 2 diabetes. So thank you so much. That's the end of my presentation.
Well, I could listen to Dr. David Unwin all day.
Yeah, very impressive, man. Look, I want to pick on a couple of things and pick your brains on them, Paul. You obviously started off talking about liver damage and specifically about gamma GT. And the inference was that was a good indicator of fatty liver and liver damage. Give us your thoughts on gamma GT or GGT, which is part of the liver enzymes that you get. When you do a standard liver function test, a blood test for liver function test, you get a whole bunch of usually half a dozen enzymes. one of which is GGT or gamma GT.
Well, we often see GGT is elevated in people with liver damage. So for that association, it certainly can be a good marker. But I like to think about what it actually represents. And it represents oxidative stress. And it's this oxidative stress that it represents that actually can damage the liver, as well as doing a bunch of other stuff. The way to think about it is that our bodies have natural antioxidant defenses. And one of the most potent of these is called glutathione. And when our bodies are suffering oxidative stress, they'll try and produce glutathione. And as a byproduct of this glutathione production, we will also produce GGT. So GGT, in effect, is a surrogate marker for when we're suffering these oxidative stresses. And these oxidative stresses can and often do damage the liver. So in the case of somebody who's drinking a lot of alcohol, we know that alcohol leads to oxidative stress, and we know that alcohol preferentially will lead to an elevation of GGT in the blood. And as an aside of that, it's also going to be damaging the liver. So GGT can be a marker of liver damage, but my preferred marker in terms of enzymes is actually one called ALT. And I know that's one that you're familiar with. So basically, in our liver cells, they contain this chemical called ALT. And if our liver cells are diseased or injured, they can burst open and they can leak this chemical into our circulation. And if we do a blood test and we detect this ALT is at a higher concentration than it normally ought be, then that's a very good indication that the liver is actually injured. So the combination of ALT and GGT can give you an indication as to the cause of liver damage. So if you had a high GGT and a high ALT, that would indicate that you're likely having oxidative liver damage, or liver damage due to oxidative stress. But not all liver damage necessarily comes from that. And I think that ALT marker is, well, it's certainly one that I use in clinic, and I probably prefer that one.
I know in my own case, I'd had elevated ALT for a number of years before I changed my diet, which was always came back with the note that it was consistent with a fatty liver. And it was up in the 60s every time I had it done. And then I went on my low-carb diet for 3 months, and my ALT came down to the 20s, which is normal. But what is normal? I mean, I know you have some thoughts on that the normal values that the labs give might be a little bit high.
Yeah, well, basically the reference ranges that the labs give, or the reference intervals, they're basically based on population averages or population means in a lot of cases. They just take the average result and they plus or minus 3 standard deviations. In effect, they try and encompass 95% of the population. And the problem with doing that is that 95% of the population is not healthy. We're being compared against a population of sick people. If you walk out your front door, it's more likely that 90% of people look sick rather than, 95% looking healthy. So if we actually have a look at the level of ALT, the lab references will often say that normal can be up to, 30, 40, or I've even seen levels up to 55 for some labs. But when we look at the data on all-cause mortality, which basically means the level at which your chance of death increases, we can see that the chance of early mortality increases with an ALT of beyond 20, not the usually recommended 30, 40, or 50. So it's just utterly, ridiculous. People need to understand that these reference intervals that doctors use to give you a tick or a cross on your blood results, they don't reflect optimal health. They're just reflecting population averages.
Well, to take another example that David alluded to was triglycerides. Now, he recommended that a level of less than 2 is what we should aim for. But along the same lines, is too high.
Well, I suspect it is. I mean, I guess it's whether you want to be healthier or whether you want to be optimal. It's really about, where the goal is. So if somebody comes in with a triglyceride of 3 or 4, then yes, we'll absolutely want to get you below 2. But if we're pushing for optimal health, I want my patients to be under 1.